Okay. Hello, everyone. My name is Chris Schroeder, and I am one of the anesthesiologists at the University of Wisconsin. And for a short period of time here, yet your editor of the ASRA News. We are lucky here tonight in that we are going to go over one of the most recent additions to the ASRA News library. One where we discuss point-of-care ultrasound and its use in the setting of COVID-19. So I have four great people here with me today, and I think I'll let each of them introduce themselves.
Okay, my name is Vivian, and I am from the University of Alberta Hospital in Edmonton in Canada. And at the moment, I'm the associate editor for ASRA News. And we have invited Harry, Oliver, and Stephen to write the article, which I think is an important article at this current moment on POCUS for COVID-19.
Hey, I am Oliver Panzer. I'm also an anesthesiologist and intensivist at Columbia University Medical Center here in New York City. I'm very interested in ultrasound. In fact, my ultrasound experience started with regional anesthesia, and my fascination with how it transformed regional anesthesia. And from there, like so many of us, slowly, I switched to POCUS, which I had a lot of use for in the critical care setting.
Hello, hi, I am Hari Kalagara. I'm the assistant professor in anesthesiology and perioperative medicine at the University of Alabama, Birmingham. I would first of all thank the ASRA Society and specifically Viv and Chris for asking us to write this article on POCUS for COVID-19. It's a really relevant article given the current pandemic and the use of POCUS, so we will discuss that one. I'm very thankful to Stephen and John for getting me into POCUS and making me use of this POCUS entity in my career. Thank you.
I'm Stephen Haskins. I'm an anesthesiologist as well. I work at the Hospital for Special Surgery, which is in New York City. That's an orthopedic specialty hospital. And my enthusiasm for point of care sort of emerged from transesophageal echo. I always say sort of basic. TE was my gateway drug to point of care because I went through the process of getting the basic certification as a CA3 as a senior resident. But then I moved on to a regional fellowship at the Hospital for Special Surgery, and as you can imagine, I wasn't doing too many general anesthetics, and I certainly wasn't doing any cardiac surgery at orthopedic hospital, and so that's where my focus shifted to point of care in the form of focused cardiac ultrasound, and was able to help bring FATE, which is one of the original sort of focused cardiac ultrasound protocols and one of the early sort of educational platforms for teaching focused cardiac ultrasound over from Europe to the US and start teaching it at our institution, which is since spread around the nation, which is very exciting, and it's now part of our ASRA Intro to Perioperative POCUS course that we hold at least once a year when there isn't a pandemic. But as a result of that, I got to go to Denmark and learn from Eric Sloth and his colleagues other point of care skills like lung ultrasound and the FAST exam, and that's where my real enthusiasm for point of care grew, and so I enjoy doing airway ultrasound now almost as much as I love doing focused cardiac ultrasound. So I'm very excited to be here, and just wanted to acknowledge the fact that Hari, put in a lot of the hard work for this article, and really kind of, laid the framework and did a lot of the writing, and we're very fortunate to have Ali step in as sort of our POCUS COVID expert, because he really was on the front lines during the original surge in New York about a year ago, working very hard to try to keep as many people going during that time. So grateful to be able to collaborate with the both of them, and thank you for having us.
All right, so that is outstanding. I would say I took your POCUS course when it was a couple of years ago, and it was outstanding. I learned just so much. Do you guys, what other mechanisms? So if you're a regional anesthesiologist out there just kind of plugging away right now, so what mechanism or what would you turn to kind of learn these skills and incorporate them into your practice?
That's a good question, Chris. I always tell to people, among the perioperative medicine and anesthesiologists, people who practice regional anesthesia should be the most convenient people because they use ultrasound more often. You do the blocks. So you are the right people to enhance the use of ultrasound in the perioperative care. So simple, like you're doing an infraclav block or an interscalene, you check for your pneumothorax routinely. So that's a way of doing your lung ultrasound. So you are doing a femoral block, check for femoral veins, look for a DVT. So you don't need to specifically go and do POCUS. While you're doing your regional, you can just advance your skills, looking into lungs, diaphragm, DVT, or any complex case, just scan the hearts. So these are just a few simple examples I'm telling where we are in the upfront. We have the machine, we have the ultrasound, we have the patient, we have an indication where we have done, and we are now looking for something which you don't have a complication or something, any sonopathology. So there shouldn't be no reason that regional people are not using ultrasound other than regional.
Yeah, I obviously agree with that, and I think that's why it's not surprising that the point of care has taken off so rapidly, and there's been so much enthusiasm within our society, American Society of Regional Anesthesia. Just as a highlight, we've recently put out recommendations for education and training for POCUS for regional and acute and chronic pain physicians. But I think it's important to take into consideration if you're a novice who's never been exposed to any of these things before, but you're hearing about it now and you're thinking, how do I pick up a probe and start learning this? And the good news is there's a lot of great resources out there, whether you're a regional anesthesiologist or not, although a lot of them are, we have a pretty robust group of articles through RAPM and opportunities to learn, like through the recommendations through the society, but there are educational platforms online that are available for free, like foresight.com, which is sort of a comprehensive head-to-toe point of care ultrasound exam. It includes things like optic nerve sheath diameter to look at ICP, pressure, airway ultrasound to look for endotracheal intubation, endobronchial intubation, esophageal intubation, a gastric ultrasound to look for contents within the gastric antrum and concern for aspiration risk, in addition to the more traditional things like lung and cardiac. So even if you're a complete novice, just know that there are resources. usabcd.org is what we use for the ASRA course, and that's something you don't have to sign up for the course to actually start doing their online e-learning. They offer that sort of on their own as well. So just ask around, look around, and a plug for the ASA Certificate of Completion, which is a new resource as well to learn point of care ultrasound, and ultimately the goal of the Certificate of Completion is to prove competency and aid in credentialing at your organization. Happy to talk about more of that later. Ali is also very much directly involved in helping create that certificate.
Yeah, I'm very, very happy that this is finally out, and I think it should be a nice opportunity for people who are interested to take this further. Like Hari and Stephen said, I think regional anesthesiologists are particularly, destined to kind of use POCUS because of their experience with ultrasound. That's, as I said, that's basically how I kind of sort of slowly went into it. I think Stephen mentioned the free websites that are there, online resources. One that I really like, who's also like teaching 3D applications, is the PIE from Toronto. It's also free at no cost. So many opportunities there, and especially during the pandemic, I don't feel like it means necessarily that you cannot pick this up. because I think the material that's available right now, even without direct instruction, gives you a lot of guidance already.
So that is great. I would tell you, I'm excited to do that POCUS certificate. I'm planning to sign up for that. Dr. Pawa in the comments asked specifically about cardiac ultrasound. So, imagine if you're somebody who's working in an ambulatory clinic, how do you approach patients about, potentially doing elective TTE exams, to keep up your skills? What is that conversation like?
I think, when it comes to the preoperative scanning, what we're talking about, I think that is a little bit different from how POCUS came about originally, which was basically in the setting of an acute deterioration. And then you kind of basically assess what's happening, and you use the pictures and findings to kind of differentiate what's going on, why the hemodynamic stability, why the hypoxia exists, what's the background. When you do that preoperatively, it's a little different, I think, because the patient's not acutely ill. So it gets a little more difficult, I think, to interpret the images accurately. And it requires a little more skill. But it is, on the other hand, I think, especially if you think about the block area, where we see patients before they go into the OR and receive their block, I think it's also a unique opportunity to actually practice ultrasound, even though with the awareness that, you got to be a little more careful to interpret the images, but it's an excellent, and I think it should be practiced, especially, as you know, with some of the regional anesthesia cases, elderly patients that have not gotten the proper follow-up or proper preparation. I think this is an important area, and I think that's going to be growing over the next years, that more and more people are going to practice POCUS.
Do you find it helpful for hip patients, with that population being so fragile already?
Absolutely.
That skill.
Yeah.
That was the initial study done for the perioperative TTE, which showed the difference in management when you diagnose aortic stenosis. That was the first initial studies which increased the value of specifically the TTE in elderly hip patients, finding out aortic stenosis, planning your anesthetic plan, whether you do a spinal, whether you need a arterial line, whether you need a post-operative intensive care, or whether you need further expert referral. So this is the patient population that really changed the TTE care, I would say. And that's a good question, Chris, as Amit was asking. Yeah, I would say most of my surprises of TTE came in ambulatory setting. In the endoscopy, ambulatory, patients come up with they don't have a good medical history. They don't go follow up. They suddenly come in, oh, I had shortness of breath. I'm not feeling well. Okay, let me scan. And you see all the surprises. Usually the big major surgeries, they are all well run through the preoperative clinics. They have a last 6 months echo. You are reasonably okay. But in my last 2 years of clinical practice, all the TTE surprises came from the ambulatory units. It's unbelievable, amazing how much you learn by putting a probe based on the patient's signs and symptoms, history. Just take a permission, quick 5 minutes, pre-op in the block room or wherever Ali was telling, makes a huge difference. Because especially these patients are going home, you pick up something, it makes a huge difference to their outcomes.
Can I add just one thing? Because I think Amit was also kind of asking a little bit about the ways that you can ultimately get to the point where you feel fairly confident with cardiac, which is the hardest of the point-of-care ultrasound skills to learn. Being able to see whether or not the lungs are moving or static, to see if there's a large pleural effusion. It doesn't take too many scans to be able to start telling the difference between what's normal and what's obvious pathology. Cardiac requires a little bit more nuance because it's harder to obtain the views and really get that really crisp apical 4-chamber view, or figure out how to optimize the subcostal view. And as is the case with anything, when you first started doing an interscalene block and your needle, it was hard to get your needle in plane. Eventually, after a certain number of practices and getting exposed to different techniques as to how to optimize getting your needle in view, you became fairly proficient at doing that block. And it's the same with something like POCUS cardiac ultrasound. You do need to have someone there to help reinforce it when you're struggling to get the view, because for someone who has like Ali and Hari and I, who've taught many of these courses, you see that the novices make the same mistakes over and over again. It's always sort of, is the probe in the wrong location? Is your orientation marker pointing in the wrong direction? So you're just not getting the right slice of the heart in order to get the view that you're looking to get. And that just comes with time and with practice. And so, one of the things that we put into the ASRA recommendations for education and training is we put some numbers, sort of how many you need to perform, in a supervised fashion versus how many you need to sort of read in order to get the visual, pattern recognition in place, so that you can tell the difference between, the normal and the qualitative pathology for these skills. And for cardiac, not surprisingly, that was sort of the biggest number. For lung and gastric and fast and airway, it was 30 performed and 20 interpreted. For cardiac, it was 50 performed and 100 interpreted. And some would argue that's sort of on the higher end of the spectrum, but when you pick numbers out, they're always a little bit controversial, so we decided to go on the more conservative end. But I would say that generally speaking, once you've performed 50 exams and you've looked at another 100 hearts, you're probably ready to go out there and start, looking at obvious pathology. The nuanced stuff that Ali's referring to, that's a skill set that really comes with a lot more time and experience, and the ability to do quantitative evaluation of valves and function, which is not really point of care ultrasound.
All right, so moving on kind of from the basic POCUS practice and into how you're then going to utilize it in the setting of COVID. I have some of the tables from your article that you published in the most recent ASRA news. I wonder if one of you might be able to go over kind of the full exam here, and then after that, I have your tables that kind of more specifically talk about lung and cardiac as well.
So basically, we adapted this table mostly from other societies, and even from the American Society of Echocardiography. They proposed the same way of doing the POCUS for COVID-19. So it should be rapid. You should look for a specific question and answer, and it should be reproducible. If you need to do it again, you should be able to do it. The most important of all is, I would say, the lung ultrasound is the most unique in the diagnosis of COVID-19. So that's why we kept that one there. So these are the unique lung abnormalities or findings that you see in the COVID-19. I think I will leave it to this one for Stephen to talk, because he has the personal experience and he can talk better than me.
Yeah. Well, I mean, and Ali can weigh in this as well, but, a very typical finding of an interstitial process, and with COVID-19, it's a viral pneumonia, generally early on before it becomes a full sort of acute respiratory distress syndrome type of scenario. And so any sort of interstitial process that has increased fluid within the lungs and inflammation of the pleura is going to present with those B lines. Those are those bright sort of rocket or lasers. They've been described as comets, but essentially they emerge from the tissue directly underneath the pleura, the lung tissue directly underneath the pleura, and they go all the way down to the edge of the screen. And so when you see that, up to 3 of those is considered normal in a patient that has pneumonia, be it viral or bacterial or any sort of interstitial process like you might see with the congestive heart failure, acute respiratory distress syndrome. That's where you're going to start seeing a predominance of these B lines. What distinguishes COVID as a viral pneumonia from something like congestive heart failure is that it's going to be patchy, it's going to be heterogeneous, it's going to be sort of predominantly in the posterior aspects of the lung. And so part of it is doing an extensive lung exam. So really sort of like what they call a lawnmower sweeping type motion. So that way you're evaluating all aspects of the lung to ensure that you're capturing all these different focal areas where you might see these B lines. That's indicative of this viral or sort of patchy pneumonia. And then as it evolves, that's where you'll see the whiteout of the lungs. As you might see in image D down there, you start to see more of these consolidations. You'll see pleural thickening, so a jagged sort of what they call sort of shredded appearance of the pleura, and you might even start to see air bronchograms like you see in C, in figure C over here, where the lung is collapsed, and you're starting to see, as the patient breathes in, sort of air making its way into the atelectatic lung. And so Hari says that I have experience with this. Ali is really the expert because he was managing these patients. I just happened to be a patient who was scanning my lungs when I had sort of a pretty nasty COVID pneumonia about a year ago, and got some images of my sort of posterior dependent aspects of both of my right and my left lower lobe, which had some B lines and some consolidations and small pleural effusions, and so I got to see it in real time. And that was my way of being able to diagnose that I had COVID, because at that point I really couldn't get any testing. PCR capability in New York City was just was not where it is now, or it's everywhere. But I'll let Ali weigh in, because he used this to help not only diagnose potentially, but really manage these patients and see how they evolved in the ICU and beyond.
So I mean, the Stephen and Hari described this already very well, and the presentation of lung ultrasound of somebody who has severe COVID was a little bit unusual in the sense that at that point they had florid, what we consider ARDS, and I can really say that these patients who were severely ill. We always think of the non-cardiogenic lung ultrasound that to have these patchy spots that Stephen described. So meaning I have areas of normal looking lung, which is lung sliding, and these horizontal repetitive lines called A lines. And the patients that I've seen that made it to the ICU or were in the step-down unit really ill, they really had no patchy areas. These lungs were completely covered with the pathological signs that we've seen. But these signs, as we presented here, were very specific for an inflammatory process, an infection process. So that, in particular, what I've seen over and over again is this B line, that the white line where the lung sliding occurs, as being very irregular, interrupted with little black spots that you can see right here. You can see at the top of the line, you can see these little black dots that interrupt the pleural line. You can also see what's really very often there, that you barely have any pleural effusion. If you have, you typically have the smaller one that's surrounding this area, like in this picture right here. Again, in this picture, you see these black areas right in going through the pleural line or right underneath, these small infiltrates that these patients have common. And you can also see that a lot of these areas, they don't have the B lines that kind of are separated nicely. Most of them are confluent, meaning that these correlate to ground glass opacities on the CT scan, meaning advanced lung disease. And here another example where you see a small effusion, this black layer above the white line, but you can see that most of the time this pleural line is not very well defined. You have lots of little interruptions. You have, again, these little infiltrates underneath it, and you see the confluent B lines, meaning you can't really separate these lines out anymore. And I have to say that, over time, we did not do that many lung ultrasound or extensive lung ultrasounds anymore, especially in the acute, severe, critical care setting, because the clinical impression already told us that, this is what you're going to find. There's a reason why they are barely ventilatable. That is it. But the other areas, especially the heart ultrasound, we did do more often in the vascular ultrasound, because unfortunately these patients are very thrombogenic and develop blood clots. They do get frequently, either because of the ventilation that they had with high PEEP values, high inspiratory pressures, or because of a thrombogenic, like a PE process. You would like to know if if there was significant RV strain, which was a picture we've seen quite commonly in these patients. So the echo definitely, after the initial excitement about doing lung ultrasound, being able to differentiate, I think personally shifted a lot to kind of looking at the echo, because the hemodynamic compromise that occurred with these patients were basically three big categories. One was an RV strain because of pulmonary hypertension from the ARDS, either a PE, which had a treatable, actually additional treatment available, or just fulminant septic shock with the bacterial superinfection that typically occurred within, I'd say, the 5 to 10 days after the admission and intubation, as a vague time period where we had to think about that. And so the cardiac ultrasound, and there again we didn't do extensive examinations, because we avoided taking big machines into the rooms because they're difficult to clean. You always have to make sure nothing's on there, so you don't carry the virus potentially out of these rooms into the nursing area, the nursing stations, or even into other patients that were not COVID affected. And so we use most of the time handhelds like the Butterfly or Lumify or whatever the names are, for these companies that offer these things, because they're so much easier to do, and typically the findings that you're able to obtain with simple, basic echocardiography were very helpful to guide our therapies. So vascular ultrasound and cardiac ultrasound, definitely. One thing I can say that the reason, at least in the initial evaluation, why we did the lung ultrasound still, was that on the rare occasion we did have patients who were in severe hypoxic failure that were labeled COVID ARDS because they had a positive test. But there are at least 2 cases I can remember where we did put the lung ultrasound on, and the lung ultrasound was completely clean. There was not one B line, and the pleural line was completely nice and smooth, no pleural effusion, nothing. And you have to think about that too. There might be the occasional patient that's COVID positive, but actually is hypoxic for other reasons. And one example in this case was that the patient had much more progressed cirrhosis than people knew ahead of time, and he had hepatopulmonary syndrome. And another patient had actually a PFO that was not diagnosed beforehand. So these are, of course, in COVID settings, not the most common scenario, but lung ultrasound might also be helpful by not finding these signs in hypoxia. Makes you think about, the relatively rare event that you don't have ARDS, you have another reason for hypoxia.
And there was a question here from Dr. Gupta here in our comments, asking that, were you able to determine a lung finding that indicated that more aggressive pulmonary support in some way would change the course of a patient's COVID progression? Intubation is both a treatment, but also potentially harmful in some of these patients. So would some of these findings help you use mechanical ventilation more carefully?
I would say that So there is good data there in ARDS patients or in patients with severe pneumonia to use lung ultrasound, and that's more than just one spot. That's like what we described in the article. You have the 12 lung zones, and where you can see, for example, if you have a lot of B-lines, consolidations, can I optimize the aeration by, for example, increasing PEEP, and then I see a reduction or a change from confluent B lines into more separated B lines. As the lung pathologies, the signs that we see is sort of a continuum going from clinically normal lungs to ARDS. On lung ultrasound, that means you go from a normal lung, which is lung sliding and A lines, to separated B lines, to confluent B lines, to then complete consolidation, like we saw in the picture C, where you have this massive lung, this solid lung tissue with the air bronchograms. So this is basically a continuously worsening lung picture, and of course the same is true when the disease resolves. So that's been used in the ICU in ventilated patients to optimize your ventilator settings. To be honest with you, in COVID patients, I was hopeful that I could use this, but let's say the lung ultrasound findings were so dramatic in terms of severe, and there was not much of a difference or not much of a utility, I have to say, that I could derive from using ultrasound to optimize ventilator settings, because for most of the patients that I had, it was the ventilator settings many times were maximized, and at that point there was not a lot of utility there. I think that the fact that I just learned from COVID is if you have a patient that progresses to get severe COVID ARDS, I think the ARDS picture is typically so severe that there's the utility of lung ultrasound in that setting was less useful. It would be interesting to hear from Stephen, actually, because you scanned yourself. I always was wondering, how soon after the resolution of COVID, the COVID pneumonia, how long did it take to see a normal lung or see your lungs actually return to normal? Because I honestly, when I discharge patients, their lungs look maybe a little bit better, but you had to look for the improvement of signs.
Yeah, I mean, I can tell you, I can actually look at the scans right now. I scan, obviously I scanned myself when I was sort of having most of my symptoms, and that's where I was like, oh, okay, well, this is real. But then later on, when I was feeling better, about 2 weeks after my initial febrile symptoms, and about a week after I had kind of hit rock bottom, and I was back out there feeling better, I still had some B lines. I still had a small pleural effusion, I remember, from sort of scanning. But then I think the next time I looked was about 2 weeks later, and everything looked clear. So my case, I mean, I had real consolidations. They weren't dramatic, they weren't large, they weren't greater than a centimeter in size, but you could see sort of that shredded appearance. You could see, pretty significant B lines and a small effusion, which I guess isn't that uncommon. Small ones, large ones are uncommon. But yeah, I would say within 3 weeks after my sort of, real worrisome symptoms, I was, back to baseline in terms of aeration.
All right, I have a couple more videos that I was just wondering if you guys could comment on here. These are TTE images, and just kind of the findings that you would find concerning or noteworthy in the setting of COVID.
I can. Yeah, Steve, why don't you go ahead?
I'll just be quick. I mean, I think the most usually when you look at an image like this, you kind of want to go from the top of the screen to the bottom, and so top of the screen you see the liver, and then what you look is you'll see the right ventricle, right atrium, and you just want to see whether or not there's any sort of black ribbon separating the liver from the right atrium and the right ventricle. And so there's no effusion, which is reassuring, no pericardial effusion, which is something that you do see with the viral myocarditis. But doing just a gross comparison between the right ventricle and the left ventricle, the right ventricle should be about 2/3 the size of the left ventricle. So in this image, it's pretty clear that it's about the same size, if not a little bit larger at certain points during diastole. And so that is a worrisome symptom or worrisome image and sign when you're looking at focus cardiac ultrasound. And then the more nuanced things that you'll notice as you kind of have looked at these enough times is you look at sort of the septal wall between the left and the right ventricle, and you can see a little bit of bowing from the right side to the left side, and that really shouldn't happen because the right side of pressure should never exceed that of the left side of pressure. And so that suggests some signs of right heart failure and potential pulmonary embolism, at least definitely someone who's showing right heart strain and failure.
Then I think this kind of demonstrates sort of your same sort of thing.
Yeah, it's very, very similar. Find a different view. This is the apical 4-chamber view. It's the same patient though. You can see that one limitation of the subcostal 4-chamber view that we've seen before is that in these patients, COVID patients, where we are particularly interested in assessing the RV size correctly, because the prevalence of RV failure, pulmonary hypertension is so high, you can see that here on this picture, the RV actually looks even bigger than it did on the subcostal 4-chamber view. And it's a common occurrence that you have to be aware of when you do the subcostal 4-chamber view, that your RV is many times foreshortened. So you got to take that with a grain of salt. If you see the subcostal 4-chamber view that we just saw beforehand, as Stephen said, it's already increased, so it's probably even bigger. And you see that here on the 4-chamber view that it indeed looks bigger. You can see that if you look at the valvular ring of the tricuspid valve, which is the lateral component where the valve leaflets insert, we trace that movement. And if you compare it to the left side where the mitral valve ring is located, you can see that the left side looks a lot more vigorous than the RV side, the right side of the heart. I should say the right side of the heart is on the left side of the image. So left side of the image where the tricuspid valve is. And typically the tricuspid valve is much more vigorous than the mitral valve side. So this is a very significant finding here, that not only is the size increased, but also is contractility very likely significantly decreased as well. And you can see, if you look at the septum, you can see the septum there tends at moments to kind of bow to the left side, which again suggests that there is RV pressure or volume overload.
All right, outstanding. And then I just have one more image here.
Yeah, this is again same. This is a different patient, I think, where you can see the so-called the septal motion that Stephen described beforehand in the subcostal 4-chamber, and that we've seen in the apical 4-chamber as well. You can see here that the ventricle, the left ventricle that's in the center of the image, does not look round anymore. It looks like a D shape more, and then it has to do that with the fact that the septum is pushed towards the LV cavity because the RV is so overloaded. And of course, if you look here again and compare the cavity size of the RV that's the RV here is located between 9 and 12 o'clock using the clock analog. You can see that that area looks much bigger than the LV cavity, again suggesting that there's significant RV strain and dysfunction, which was a common occurrence in these patients. the clinical aspect that is difficult for the clinician here is to find out why. Because, as I said earlier, this could just be caused by long-term ventilation of PEEP values of 18, 20 at times, or indeed because of a PE, where thrombolytic and therapy might be an option if detected early enough.
All right. Well, I think this has been great. If you guys would maybe be able to go through and just kind of give some parting thoughts here, things that you've learned from this, and then, how maybe you'll use this in the future, that would be great.
I can start if that's okay.
Mm-hmm.
So I think, I've learned a couple of things. I think just technically pragmatism, uses the smallest ultrasound you have available, because it's with everything that comes with COVID, these little devices are extremely helpful, because they allow more fluent, more swift movement between the patients and a quicker exam than using our traditional machines. I think, as I said, lung ultrasound I expected a lot from it, and it helped me, solidify the diagnosis, but I didn't find it as useful as I thought it would initially. But the simple heart exam, and I think particularly focusing on the costal four-chamber view because of the overblown lungs, the other views were difficult to get, so the subcostal view became more and more the number one go-to image that, delivered the best results in terms of finding a quick answer what's going on with this patient. So, and I know we've been teaching that in the ASRA courses all along, but it found its confirmation here in managing these patients.
How are you?
Yeah. So exactly. So I would say I was not using that much of lung ultrasound before and DVT scan before. So with these COVID cases and this COVID pandemic, I would say my teaching or my ability or my confidence of using a lung ultrasound and DVT, even the cardiac ultrasound, has increased enormously, because ours was a level 1 trauma center. We used to do a lot of COVID positives coming for the trauma and everything. So, and most of the times you can't rely on the PCR testing, and sometimes they won't come. We have a good example. We are presenting in the next ASRA meeting. We had a COVID positives coming for rib fractures, multi-trauma. We did ESP blocks on them. So that was our opportunity to scan, see how the lungs are. And we used to, when we go to daily follow them, we used to scan ourselves and see, learn ourselves. This is a good opportunity, I felt, increasing the area of expertise in other POCUS areas. So that's the important thing. I would highly recommend reading the recent articles by Stephen from the RAPM, recommendations, how to increase your POCUS skills, how to train yourself, getting into ASA. Please use the RAPM articles, use the ASRA POCUS course, scan. Use anyone as your mentor, anyone in our hospital, just follow them, use them as a mentor, use them as a guide, keep scanning, you'll learn it. Yeah.
I would say that, with every sort of dark cloud, there's a silver lining. And with this pandemic, I think it did really highlight the importance of point-of-care ultrasound, in a way that maybe didn't resonate so much beforehand. And as Ali alluded to it, one of the benefits of it was the ability to do such a comprehensive evaluation of the patient, cardiac, lung, volume status, DVT at the bedside, without having to transport that patient to a CT scanner and back and potentially expose people along the way, or have to bring in, radiology techs and echo techs and, ultrasound technicians to perform all these exams. If you had someone at the bedside that was competent and capable of performing those exams, and you could get a lot of really important and meaningful and sort of game-changing information to help guide clinical care in that sort of setting. And so one of the things that really stood out to me is when early on the American Society of Echocardiography put out recommendations for point-of-care ultrasound. To me, that was a big cultural shift, because the American Society of Echocardiography, they are cardiologists. They represent the purest form of echo, and it's been a little bit controversial. Focused cardiac ultrasound, echocardiography. What are the definitions? Where should it be used? What does it mean to bill for X, Y, and Z? And to have them come out with a full-on support for the use of at bedside, focused cardiac ultrasound, lung exam, vascular. I think it really spoke to the fact that this pandemic brought the importance and the relevance of point of care really to the forefront. We're fortunate to have an opportunity to talk about some of the indications with this article. But if you're still out there working on the front lines, it's a good thing to learn. Even if you're not necessarily in the ICU, maybe in the emergency room, you're triaging patients. That's the scenario where it's good to be able to take a quick look and use it to guide management.
Yes, I think you're all absolutely brilliant at trying to teach us about POCUS and its use in COVID, especially with the pathogenesis, is absolutely relevant. And also, thank you for agreeing to put out a series of the POCUS scanning in future edition for ASRA News. Really appreciate that. And just funny that you mentioned the handheld ultrasound being very useful, Oliver. We are going to have an article on handheld ultrasound in our August edition, and also about capturing the ultrasound images in the August edition as well. So watch the space.
All right. Well, Vivian, thank you for putting these awesome articles together. And Oliver, Stephen, and Harry, thank you very much for putting this particular article together. I hope this is really helpful for everyone. I know it's been helpful for me. And I hope you have a good night.
Thank you.
Thank you all.
Thank
you all.
Thanks, everyone.
Happy scanning.
Yes.
Happy scanning. I like that.